Hello students, welcome to Physics Wala Meded, and in this YouTube session we are going to revise quickly the important recently asked questions from the INICET. Now we all understand INICET, there are reasonable number of repeats, right? Like at least 1/3 of the questions are direct repeats or they're based on the topics which are repeated from the previous sessions. So focus will be on the previous question. So let me start with the question number 1 without wasting your time. This is the question number 1. Please go through the question. Here we have a chronic cigarette smoker who presented with, he has now joined a construction company. His pulmonary function test results are given below. What is the most likely diagnosis for this patient? Okay, look at the lung volumes. His initial lung volumes were FEV1 was 0.9 liter, right? When someone presents with chronic respiratory complaints, what is my area of interest on a PFT? It will be primarily FEV1, then FEV1 by FVC ratio, right? Mainly I'm looking at FEV1 by FVC ratio to decide whether I have a restrictive lung disease or obstructive lung disease, right? Okay, so here the initial FEV1 was 0.9 liter and FVC was 1.9 liter. FEV1 by FVC ratio was 0.4, right? Let me write it down here again, 0.4. That is the FEV1 by FVC ratio here, 0.4. After bronchodilation, FEV1 was 1.9 liter and FVC was 3.9 liter. And the FEV1 by FVC ratio remains 0.4. Okay. Now we have to choose the option. Is it a vascular disease with bronchodilator reversibility, or is it restrictive lung disease with bronchodilator reversibility? Is it restrictive lung disease without bronchodilator reversibility, or is it obstructive lung disease with bronchodilator reversibility? What should be the answer? Obviously, when FEV1 by FVC is less than 0.7, we know it is indicative of obstructive lung disease, right? Whenever it is less than 7, it indicates obstructive lung disease. So in this case, pre-bronchodilator FEV1 by FVC was 0.4. So that clearly tells us that we are dealing with a case of obstructive lung disease. And here there is only one option which says obstructive lung disease, and that is option D. So in all probability, that is going to be the right answer. Now, the issue here would be whether this is associated with a positive bronchodilator response or not. How do we assess that? By looking at how much FEV1 improved after administration of a bronchodilation, right? After administration of the bronchodilator, it increased from 0.9 to 1.9 liter, right? It is almost 100% plus improvement. 0.9 to 1.9 liter, 100% plus improvement. Whenever bronchodilator reversibility test shows more than or equal to 12% increment in FEV1 after administration of a bronchodilator, that indicates that you have a reversible obstruction. That indicates that you have a reversible obstruction. So now what type of obstruction we have? Reversible or irreversible? Clearly we have a reversible obstruction here because there is more than 100% improvement. So option D becomes the logically right answer. Obstructive disease with the bronchodilator reversibility. That would be the answer for this question. Now let's move to the next question. Here is the question. A person presents to the hospital with fever and chills. Now at this point of time, my differential diagnosis is quite wide. Fever profile is ordered and it is found to be negative for malaria. Okay, one of the common infections in India. What test they have done? I don't know. It's negative. Dengue also, they have told that it is negative. Now they are telling us that there is a test called RK39 which is found to be positive. Now for what purpose we use this test? We use this test for diagnosis of visceral leishmaniasis, right? We use it for the diagnosis of visceral leishmaniasis. Now the diagnosis is confirmed. We have a case of visceral leishmaniasis. What would be the treatment of choice? Mostly when it comes to visceral leishmaniasis, we treat those patients with either amphotericin B or drugs like antimony. And I do find amphotericin B as an option here in option A. So that would be my answer of choice for this question, right? RK39 for visceral leishmaniasis. What we can use? Amphotericin B. So let's move to the next question. Here is the question. Which of the following is not a cause of central cyanosis? Simple and straightforward question, right? What are the options? Methemoglobinemia, pulmonary arteriovenous fistula, high altitude and hypothermia. I think all of us know the answer. The answer would obviously be hypothermia, because hypothermia can cause cyanosis. How it will cause cyanosis? It will cause cyanosis by peripheral vasoconstriction, and vasoconstriction is happening in the periphery. So can we call it a central cyanosis? No, right? So hypothermia would be our answer here because it causes peripheral vasoconstriction. It is a cause for peripheral cyanosis. Everything else will be considered as causes for central cyanosis. They are all causes for central cyanosis. Okay, so that's it over here. Let's move to the next question. So here's the next question. Which of the following drug is not used for the emergency or immediate management of hyperkalemia? Again, please note they're talking about hyperkalemia and not hypokalemia. Okay. Now, when we look at the options, what are the options we have got? We have got a 10% calcium gluconate over 10 minutes, right? Which is equivalent to 1 gram of calcium gluconate, right? Calcium gluconate. Now, why do we use calcium gluconate in hyperkalemia? We use calcium gluconate in hyperkalemia primarily with the intent of reducing the impact of high potassium on the myocardium, right? We want to reduce the risk of arrhythmias which can be triggered by hyperkalemia by giving calcium gluconate. Do we do that? Yes, we use it as an acute management. Then number 2, salbutamol nebulization. Salbutamol nebulization. How salbutamol helps? Salbutamol helps in the case of hyperkalemia by causing shift of potassium from extracellular to intracellular compartment. So it can be used for acute treatment. So I'm going to use calcium gluconate for sure. I'm going to use salbutamol nebulization also. Now, insulin dextrose combination, right? We all know insulin causes shift of potassium from extra to intracellular component, and generally we combine it with dextrose to prevent against the hypoglycemia caused by insulin. Okay, logical. Can I use it in acute setting? Yes. Now coming to injection magnesium sulfate, is it of any use in the acute setting or even in the chronic setting? Remember, hypokalemia is often associated with the hypomagnesemia. So probably hypokalemia, which is refractory to potassium loading, may be helped by giving IV magnesium sulfate. In a case of hyperkalemia, it has no role or no value, and that would be our answer over here, right? So the answer for this question is option D. Okay, now let's move to the next question. Here is our next question. Now, what is the question about? Identify the conduction abnormality from the ECG given below, right? They have already told that the question is about conduction abnormality. Now guys, students, please remember ECG, especially in the exams or even for that matter, even in clinical practice, always read it in the context. Don't read it out of context. This is one of the common mistakes that I see. Sometimes I've seen my postgraduate students standing in the emergency room, wasting 10 minutes on the ECG when they have a critically ill patient because they want to diagnose everything on the ECG. It's not so important to diagnose everything on the ECG. Primarily focus on the context, right? If the question is about a patient with chest pain, then look for the evidence of the ST elevation, MI, and evidence of the acute pericarditis. If the question is about palpitations, right, then look for the arrhythmias, tachyarrhythmias. If the question is about the loss of consciousness, syncopal episodes, then, or if there is bradycardia in the case, then look for the blocks. So when you are focused, you will be able to diagnose ECG based questions quickly without wasting your time. Now here the question is about conduction abnormality, already told. So my focus will directly shift to AV blocks, right? We know different types of AV block. First degree AV block is what? First degree AV block, there is serial prolongation of, the first degree AV block is where you have a prolonged PR interval, persistently prolonged PR interval. Now what is the normal PR interval? Your prolonged PR interval. Okay. Now what is a normal PR interval? Now remember here, the normal PR interval is in the range of 120 to 200 milliseconds. 120 to 200 milliseconds. Now on a ECG which has a standard speed set, that is 25 millimeter per second, each small square represents 40 milliseconds. So when I say 120 milliseconds, that means 3 small squares. When I say 200 milliseconds, 5 small squares. So on an ECG, in a standardized ECG, PR interval is expected to occupy 3 to 5 small squares and nothing more than that if it is occupying more than 5 small squares, that means more than 200 milliseconds, that's clearly abnormal. That means the PR interval is prolonged. Now let me bring in one more important point here. Okay, so I'm going to mark on this ECG two markings. Okay, one is between two yellow lines. Okay, between two yellow lines. Then I'm also marking with pink lines. Okay, what do you think is the PR interval? Between the pink lines is the PR interval, or between the yellow lines is the PR interval? Which one is PR interval, the pink one or the yellow one? Now remember this one point, guys. In the ECG, whenever you use the word interval, it always means that it includes a wave. Intervals always include a wave. But when it comes to the segments, like for example, you're familiar with ST segment. Segments do not include a wave. So when I say PR interval, it includes the P wave. From the beginning of P wave to the beginning of QRS complexes. That is your PR interval. And from the end of P wave to the beginning of QRS complexes, that is PR segment. PR segment. So to detect the AV blocks, I'm interested in PR interval. Okay, so in first degree AV block, there is prolonged PR interval, but there will be no missed QRS complexes. There will be no missed QRS complexes. No missed QRSs. Okay, now if you say ventricular tachycardia, how to identify it on the ECG? Number one, you say there will be tachycardia. Heart rate will be significantly high, maybe more than 200, 300. At least you can say it should be certainly more than 200 to call it as ventricular tachycardia. Then there will be wide QRS complexes. Wide QRS complexes. Now, when do I call it as wide QRS complexes? When your QRS complexes are normal, QRS complexes should occupy less than 3 small squares. Means it should be less than 120 milliseconds in terms of duration. If they are occupying more than 3 small squares, it is clearly abnormal. When I say that, that means more than 120 milliseconds, which is equivalent to 3 small squares. So here, is it occupying more than 3 small squares from the beginning of Q to the end of S? Certainly not. So there is no 3 or more than 3 small squares. It is less. So it is narrow QRS complexes. There is neither tachycardia nor wide QRS complexes. So this cannot be ventricular tachycardia. Okay. Then in third degree heart block. So what happens in third degree heart block? In third degree heart block, there is complete AV dissociation. What does that mean? Now, if you look at a normal ECG, what you will notice is you will have a P wave, it will be followed by a QRS complex. Then again, you will have a P wave, it will be followed by a QRS complex. On a normal ECG, if I pick up a QRS complex, I will always find a P wave behind it, right? Because in normal heart, the depolarization starts from the SA node, depolarizes the atrium, then AV node, then through the bundle, then bundle branches, the entire ventricle gets depolarized. But the depolarization wave always starts in the atrium. So atria is the one which is getting depolarized first. So you'll always have a P wave followed by QRS complex. Okay. Now in the first degree AV block, as I've already told you, the PR interval is prolonged. Now what does that mean? That means the wave of atrial depolarization is taking a long time to reach the ventricles. That's why ventricular depolarization is now getting delayed. That is why PR interval is delayed. Clear? Okay. But there will be no missed QRSs in case of the first degree. Okay. In case of third degree, what happens is, in third degree, you will have a complete AV dissociation. That means atria and ventricles are dissociated. Now, what does that mean? That means atria is contracting on its own, ventricle is contracting on its own. Both of them are having their own pacemakers. So now, can I see this relationship between the P wave followed by QRS complex, again a P wave followed by QRS complex? No. So P waves may be there, may not be there. If P waves are there, they may not follow this temporal relationship with the QRS complex. You may find P waves buried into the QRS complex. You may find P waves after the QRS complex, and you may also find them before the QRS complex. Anything is possible. This is what we call as AV dissociation. Do you see any such relationship? Okay, I do identify a missed QRS in that location, but other than that, P wave followed by QRS, P wave followed by QRS, P wave followed by QRS, P wave without a QRS, but otherwise P wave followed by a QRS. Don't you think that the P to Q relationship is maintained except for this missed QRS? Yes, so then it can't be third degree AV block. Okay, now coming to the next option, second degree heart block. Now what happens in second degree heart block? In the second degree heart block, there are two types. We have one known as Mobitz type 1. Mobitz type 1. Okay, so now what happens in Mobitz type 1? In Mobitz type 1, there is serial prolongation of PR. Serial prolongation of PR interval till you encounter a missed QRS. Till a missed QRS. So you will miss a QRS and then again the cycle will continue. Does this ECG fit into that? Serial prolongation of PR interval, then a missed QRS, then again the cycle continues. Does it fit into that? See, look at this. Look at the PR interval here. Okay, let me use this a different color so that you can relate to what I'm saying. So look at the PR interval here. Okay, look at this PR interval. Look at the PR interval here. Don't you think it is serially increasing and then you have a missed QRS? Again, the PR interval is similar to what it started with. If I follow this ECG further, I will encounter one more missed QRS. So does it fit into the Mobitz type 1 second degree heart block? Yes, it does, right? So my answer for this question will obviously be option D. It fits into the Mobitz type 1. Okay. Now before I move to the next question, let me also tell you what do I see in Mobitz type 2, right? We also have a Mobitz type 2. Now what do we see in Mobitz type 2? In Mobitz type 2, there will be missed QRSs. Just like how we see in Mobitz type 1, there will be missed QRSs, but there will be no serial prolongation of the PR interval. The PR interval will be constant with constant PR interval. Constant PR interval. So obviously this ECG doesn't fit into it because there is serial prolongation of the PR interval. So it's not Mobitz type 2, but it is certainly second degree heart block, and that's my answer for the question. Okay, now let's move to the next question, guys. This is the question. What is the question? The absence of loud S1 in mitral stenosis would indicate all of the following except, right? Now S1, as we know, is due to closure of mitral valve and tricuspid valve. So it has two components. Mitral closure causes M1, tricuspid closure causes T1. M1, T1 combined makes S1, right? The classical example for loud S1 is your mitral stenosis. We always consider it as a classical example, right? So S1. Now this S1 can be loud in case of mitral stenosis. And I want you to remember one more equally important cause, that is short PR interval. Short PR interval. Short PR interval. Like these two are important causes for loud S1. Okay. Now what makes the S1 to get softer in mitral stenosis? Okay. First thing I would tell you is think about mitral regurgitation. If there is mitral regurgitation, what is happening to the mitral valve? It is not closing. So if it is not closing, will you have M1 there? No, right? So if you remove M1 from the S1, then what will happen to S1? It will become soft. So anytime MS is added with MR, it will obviously become soft. So do I have that option? No. Okay. Second, if you have a valve which is calcified, then it may not close properly. So when it is not closing with a third, it will not produce a loud S1. So calcified valve is a known cause for the softness of loud S1 in case of mitral stenosis. Okay. Then first degree heart block. Think about it and tell me what will happen to the loudness of S1. Normally S1 will be loud when the PR interval is short. Okay. Now what happens in first degree heart block? First degree heart block is associated with prolonged PR interval. So when there is prolonged PR interval, S1 will become soft. So it can happen in the first degree heart block also. Okay. Now mild mitral stenosis. Now more severe the mitral stenosis is, loud one, S1 might become loud. The loudness may be reduced. So mild mitral stenosis, like when I say more severe, very severe mitral stenosis, when the valve gets calcified, the S1's loudness will be lost. Okay. And if it is very mild, very mild, it may not also cause the loud S1. The moderate mitral stenosis, which is typically known to cause loud S1. So mild mitral stenosis, you may not experience loudness. Now coming to aortic regurgitation. Do I expect a patient with aortic regurgitation to develop loss of the S1's loudness? The answer is no. Aortic regurgitation, see, S2 is formed by aortic closure A2 and pulmonic valve closure P2. In aortic regurgitation, aortic valve is failing to close, so there is no A2. If there is no A2, what will happen to S2? S2 will become soft. The soft S2 will be seen in patients with aortic regurgitation, and you have no direct impact on the S1 if it is AR. So what should be my answer here? Obviously it will be option B. That would be my answer. Okay, so let's move to the next question now. So here's the question, guys. The question is, thrombolysis can be considered in all of these conditions except. So we are actually talking about the stroke management, right? Now before I even address thrombolysis, let me ask you a question. What is the best treatment as of now that we can offer to a patient with acute ischemic stroke if they present in right time? You may be thinking thrombolysis, but let me tell you, it is not. The best treatment that we can offer to any patient of acute ischemic stroke is, right, that is going to be mechanical thrombectomy, something similar to what we do for the heart, angioplasty. Its counterpart for the brain, that is mechanical thrombectomy, literally retrieve the clot from the blood vessel. It is technically feasible only when the block is in a large blood vessel, right? Okay, now coming back to thrombolysis. They are asking about considered in all of these conditions except. So basically this question is about contraindications for the thrombolysis. Okay, now option A, MRI showing density in less than 1/3 of the area supplied by MCA. If it is more than 1/3 of the area supplied by MCA, it is a contraindication. So this can be an indication. I will just certainly go ahead with that, right? Then blood pressure of more than 185 by 110 millimeters of mercury. We all know this number as a contraindication. When BP is more than 185 by 110 millimeters of mercury, it's a contraindication. To be more precise, it's a contraindication when we are not able to lower the blood pressure despite treatment. Despite treatment, it's a contraindication. If you have sufficient time, patient is well within the window period, you have sufficient time to lower the BP, you can take the patient for thrombolysis. यहाँ पे patient if presents after the window period, or if you're not able to lower the BP to a target less than 185 by 110 despite treatment within the window period, then it is a contraindication. Flat out taking it as, I will still consider it as a contraindication. Now ischemic stroke within 2 hours, right? Up to thrombolysis can be done up to 4.5 hours, right? And we should also remember maximum benefit of thrombolysis can be derived when it is done within 3 hours, but up to 4.5 hours, the benefits always outweigh the risks. So we can go for this. This is a indication for this case, right? Now onset of symptoms. Again, it is talking about presentation within 4 hours. I told you up to 4.5 hours we can certainly consider. So both of them are indications. So MRI showing density less than 1/3 of the area supplied by MCA is an indication. Option C and D are also indication. Option B is the only contraindication. And when they said except, basically they ask us to identify a contraindication for thrombolysis, and that contraindication for thrombolysis would be in option B, right? Option B would be the answer to go for there. Okay, so guys, let's move to the next question. Here is a question. A 50-year-old male patient presented with left-sided hemiparesis. Left-sided hemiparesis. Damage to which part of the internal capsule leads to this presentation? So they have only mentioned hemiparesis. So when I look at the options, right, see, first of all, when you think of someone having hemiparesis, when you think of someone with hemiparesis, we have to think of localization into three important locations, right? First location would be your brainstem. First location will be brainstem. So if there is a brainstem hemiplegia, what will be the manifestation? This typically leads to crossed hemiplegia, right? What do I mean by crossed hemiplegia? When I say crossed hemiplegia, I'm saying there is cranial nerve involvement because brainstem has cranial nuclei, they are getting affected, and there is hemiplegia. But why am I using the term crossed hemiplegia? Because here cranial nerve involvement is on one side and the hemiplegia is on the other side. And which side there is cranial nerve involvement? On the side of lesion. That means ipsilateral side cranial nerve involvement. So when I say crossed hemiplegia, it means a combination of ipsilateral cranial nerve palsy, okay, plus contralateral hemiplegia. Now, can this patient that we saw fits into crossed hemiplegia? No, they have not mentioned about the cranial nerve involvement. So it is unlikely to be a case of brainstem location, right? The next thing we encounter is your subcortex, right? Subcortex. And on top of that, we have cortex. Now, if I have a cortical hemiplegia, typically that patient is going to present to me with, what will be the presenting complaints? The cortical hemiplegia patient will present with hemiplegia plus, in addition to hemiplegia, these patients will also have cortical features, right? What are the cortical features? Cortical features include seizures, loss of consciousness, aphasia. Cortical features, right, that include seizures, altered mentation or loss of consciousness, and aphasia. So if these are present, strongly think of cortex as a site of lesion. Now, in subcortex, though stroke can happen at multiple level, internal capsule is the most common site. Internal capsule is the most common site. Internal capsule is the most common site of subcortical stroke. And here we have to remember that the motor tract or the pyramidal tract passes through the posterior limb of internal capsule. So if the infarct affects only the posterior limb of the internal capsule, we will develop what is called as pure motor stroke without any sensory involvement. Posterior limb of the internal capsule stroke leads to what you call as pure motor stroke. Pure motor stroke. Okay, now let me get back to the question. With this information, can I say that this is a cortical stroke? No. With this information, can I say that this is a brainstem stroke? No. I have to mostly think of internal capsule. And remember here, they have only told hemiparesis. They are not talking about the hemisensory loss. So it has to be pure motor stroke. Now, if it is pure motor stroke, where should be the lesion? So this case has pure motor stroke and the lesion has to be in posterior limb of the internal capsule. Posterior limb of the internal capsule. So the answer should be option D over here. Okay, now let's move to the next question. What is the most common site of abdominal tuberculosis? This is a very simple, straightforward, repeatedly asked question. The most common site of abdominal tuberculosis is usually iliocecal junction. Why iliocecal junction is the most common site? How tubercle bacilli reach the ileocecal junction? Mostly by patients who cough out. They have tubercle bacilli in the sputum and they swallow the sputum. The swallowed sputum is generally inoculated in the ileocecal junction, making that as the most common site for the bowel tuberculosis. Okay, let's move to the next question. Here is a question. A woman presented with altered sensorium, breathlessness, hypotension and bradycardia. Okay. Examination revealed non-pitting edema of the extremities. Remember here, I am drawing your attention again, which is the nature of edema here. The nature of edema is non-pitting. Non-pitting nature of the edema, not pitting. Okay. Now, she has a long history of weight gain, constipation, cold intolerance, right? If you see these symptoms, what comes to your mind? Obviously, to my mind, what comes to my mind is mainly hypothyroidism. This would make me think this is a case of hypothyroidism. Hypothyroidism. Because in hypothyroidism, there is decreased basal metabolic rate. That is why patients will have cold intolerance. They will have constipation. They will have weight gain. Higher the basal metabolic rate, at rest your body burns a lot of calories. Lower the basal metabolic rate, your body is not able to burn large quantity of calories. That's why you gain weight. Okay, non-pitting edema, does it fit into hypothyroidism? Yes, we call it as mixed edema. Everything is fitting into mixed edema. And now this mixed edema is presenting with a severe clinical condition. So this is exactly what we call as mixed edema coma. The answer should be mixed edema coma. This is not septic shock. To call it a septic shock, there is no pointers towards infection. There is no pointer towards any other organ involvement and no evidence of, no other information provided for me to think of septic shock. Can't call it as cardiogenic shock because I have clear-cut glaring information about the hypothyroidism. Can't be hyperthyroidism either. So option C would be the correct answer. Okay, now let's move to the next question. Here is a question. What is the question? Which of the following does not help in the localization of lesions in the spinal cord? Let me read through the options. Contralateral hemiplegia. Contralateral hemiplegia. Okay. Then fasciculations at the level of lesion. Then upper motor neuron lesion and lower motor neuron lesion. Bladder involvement. Okay. Now, let me tell you, when you look at the spinal cord, right? What is the spinal cord? Spinal cord is the structure through which the ascending and descending tracts are passing through. So you have the tracts coming down from the cortex down to spinal cord, and then you have tracts ascending up. And what are the tracts that are coming down from the cortex to the spinal cord? Most importantly, the one that I'm particularly concerned is pyramidal tract, right? Pyramidal tract. Pyramidal tract. Now, what is the journey of the pyramidal tract? The pyramidal tract begins in the motor cortex, passes through the brainstem. So this is, if my brain, right, I have motor cortex. This is my motor cortex, and the pyramidal tract is going to begin from the motor cortex. Motor cortex is going to be all collection of your cell bodies of the motor neurons. You call it as, and you call them as bed cells. From there, a tract will be formed. This is what we call as pyramidal tract. Okay. Now this pyramidal tract is going to pass through important or major structures. What are the major structures? It will pass through the internal capsule, then through the midbrain, brainstem, pons medulla, midbrain pons medulla, and then the spinal cord. Okay. So this tract, as we know, right, this will decussate at the base of the medulla. They will cross down at the base of the medulla to opposite side. This is what we call as decussation, right? And then the tract will continue to descend down in the spinal cord as pyramidal tract through its white matter, right? Then the spinal cord will also have tracts which are ascending up and taking the sensation from the periphery to the brain. That is going to be One of them is carrying the pain sensation, that will be spinothalamic tract. The neurons of the spinothalamic tract, as soon as they enter into the spinal cord, they will cross to the opposite side, ascend on the opposite side and reach the opposite thalamus, right? This is your pain and temperature fibers. The tract will be called as lateral spinothalamic tract. Okay, so same applies to the other side. Now we have one more important sensory pathway, that is dorsal column. Now the story of dorsal column is going to be little different. In what way it is going to be different? The fibers of the dorsal column, as they enter, they will ascend up on the same side, they will cross in the medulla and then go to their respective sided thalamus, right? This is your spinal cord. Now this is our spinal cord, that is our area of interest as of now. Okay, now in the center of the spinal cord, what do we have? In the center of the spinal cord, we have the central gray matter, right? We have the gray matter. So here we have this gray matter. Okay, so just to make it a little more clear to you, I will use the slightly white color. This is your central gray matter. Now gray matter has anterior horn cells, and in the anterior horn cells are basically the cell bodies of lower motor neuron. So from this pyramidal tract, the pink colored tract that I have drawn, whenever a neuron needs to exit, it will exit to the center of the spinal cord and it will try to synapse with the next cell, that is your anterior horn cell, from which a peripheral nerve comes out, right? So a motor neuron's journey started where? It started mainly from the motor cortex, then continued all the way on the same side in the brainstem, then crossed to the opposite side and then continued in the spinal cord, right? And then when it has to synapse with an appropriate segment, it will come out, join the or synapses with the anterior horn cell. From the anterior horn cell, we will have another neuron coming out. So from cortex to anterior horn cell, right, the one that is synapsing with the anterior horn cell will be called as upper motor neuron, and from the anterior horn cell to the muscle will be called as lower motor neuron. Okay, now when I cut the spinal cord, if I cut the spinal cord at some segment, let me say I have cut the spinal cord in this segment. Now tell me what all is happening on the same side. The pyramidal tract is concerned with the same side that is getting damaged, because the right motor cortex is regulating the left side of the body, and that is cut in the spinal cord. So it is going to cause same side motor weakness. So motor weakness will always be on the same side. So spinal cord lesion is going to cause motor weakness on the same side. Spinal cord lesion will cause, number one, motor weakness, always on the same side, on ipsilateral side. Okay, now number two, at the level I'm cutting, I'm also doing the damage to anterior horn cell, right? At the level, below the level, all the upper motor neurons coming through the spinal cord are lost. So what will I see? I will see element type of weakness at the level, element weakness at level, at the level of damage or at the level of lesion, and I will have UMN type of weakness below the level of lesion, weakness below the level. Okay, now because spinal cord is contributing to the sacral segments and it's also concerned with autonomic nervous system, you will certainly have the bowel and bladder dysfunction. So you will have bowel and bladder dysfunction, bowel and bladder dysfunction. Okay, now if I cut only at half level, we call it as Brown-Sequard syndrome. In that case, opposite side pain and temperature fibers, like if you trace it, you will notice that the opposite side pain and temperature fibers are not reaching the thalamus. So opposite side will lose pain and temperature sensation. Ipsilateral side, that is your vibration and proprioception carried through dorsal column, that will be not able to reach the thalamus, but opposite side dorsal column sensations will be able to reach the thalamus. So you will have ipsilateral weakness, you will have ipsilateral loss of vibration and joint position sensation, right? So you will also have ipsilateral vibration and proprioception loss. So what is happening at the opposite side if I am sectioning the spinal cord? It is the loss of pain and temperature that is happening on the opposite side. Now let us get back to the question and see if we get the answer right this time. Okay, so here's the question. Does not help in the localization of the lesions in spinal cord. Number one, bladder involvement. Yes, bladder involvement is typically known to occur in spinal cord disease, so it can help me. Upper motor neuron lesion. Yes, because we are cutting the pyramidal tract, so you can have upper motor neuron lesion plus lower motor neuron lesion also, because the anterior horns are also getting damaged, right? Anterior horn damage and upper motor neuron because of the pyramidal tract damage. So both can happen. Pyramidal tract damage. Now remember, upper motor neuron damage will be below the level of the lesion. Below the level of the lesion, and lower motor neuron damage will be at the level of lesion. At the level of lesion. Okay. Now option B, fasciculations at the level of lesion. Yes, because at the level of lesion, we will be seeing lower motor neuron type findings. So whatever is the level, like let me say C6 or C7, the muscle supplied by the C5 segment or a C6 segment where there is lesion will be showing atrophy and fasciculations, which are hallmarks of LMN lesion. So B also can help me, right? Option B, C, D can help me. Contralateral hemiplegia? Certainly not. In case of spinal cord disorders, we are expecting to see ipsilateral loss of motor strength, not contralateral. So option A will be the answer over here. Okay, let's move to the next question now. Okay, so this is a question. Which of the following is not a feature of Brown-Sequard syndrome? So in the previous question only, I have already told you, if you do hemisection of the spinal cord, on the same side, you lose motor strength and vibration and joint position sense. On the opposite side, you lose the pain. Okay, so basic thing to remember Brown-Sequard syndrome is opposite side pain. How to remember it? Simple, right? If you hurt someone, the person who hurt doesn't experience the pain. The one who got hurt gets the pain, right? Similarly, यहाँ पे lesion is on one side, the pain is getting affected on the other side. I know it is the loss of pain and temperature, but this way you can remember the pain is getting affected on the opposite side. Okay, so now answer the question. Complete transection of the spinal cord? No. There is a hemisection of the spinal cord. There will be hemisection of the spinal cord. Then we call it as Brown-Sequard syndrome. So probably we found our answer. Anyway, ipsilateral loss of vibration and touch. Yes, the loss of vibration, touch and joint position will be on the ipsilateral side. Contralateral loss of pain and temperature. Yes, I have already told you. जिसने hurt किया उसको नहीं होगा, जिसने hurt नहीं किया, pain हमेशा opposite side पे. यहाँ पे भी जो pain का loss है opposite side पे. Okay. Then ipsilateral loss of proprioception. Yes, that's also true. So which is the answer? Option A becomes our answer for the question, right? That would be the answer. Okay, let's move to the next question. So here's the next question. What is the question? The following clinical examination was performed. What lesion would cause an exaggerated reflex? So what are they doing here? They're doing an ankle reflex. What is ankle reflex? One of the deep tendon reflexes. So when deep tendon reflex will be exaggerated deep tendon reflex indicates an upper motor neuron lesion, right? It will be exaggerated in upper motor neuron lesion. So now find the answer and tell, right? Polyneuropathy, right? When you say polyneuropathy, you're talking about peripheral nerves. Peripheral nerves contain what? Peripheral nerves contain lower motor neuron. Peripheral nerves contain lower motor neuron. So when I say radiculopathy, right? Again, radicals contain what? Lower motor neuron. Lower motor neuron तो obviously नहीं हो सकता है because there will be hyporeflexia. So what is the correct answer? Option C will be the right answer for this question. Okay, let's move to the next question now. Here is the question. A 65-year-old female patient was weighing 60 kg on a mechanical ventilation for ARDS secondary to urosepsis. The respiratory parameters are as follows. The tidal volume is 360. Let me address this point here, right? ARDS, what is the recommended setting for ventilation in ARDS? In case of ARDS, right, ventilatory strategies. Important MCQ topic for the INICET. Recommended ARDS ventilatory strategies. What is recommended? Number one, most importantly, with respect to tidal volume. How much you want to give the tidal volume? So we clearly know by now that the recommended tidal volume strategy is low tidal volume. The tidal volume should be low tidal volume. And when I say low, what does it mean? Around 6 ml per kg. That is a recommended tidal volume. When you say low, 6 ml per kg. Normal, 10 to 12 ml per kg. So we will go back to the question and see if the treating physician is following the appropriate number. 60 kg, 6 ml, 360 ml, right? The setting is right? Okay. Now, the next important parameter that is of concern is the PEEP, positive end expiratory pressure. Positive end expiratory pressure. Now here, the recommended strategy is to have high PEEP strategy. Why high PEEP? What is PEEP? Positive end expiratory pressure. Means you need to keep higher pressure at the end of expiration. How is it going to help? See, in ARDS, the alveoli are inflamed, damaged. Now, if I keep a negative pressure at the end of expiration, let me say not negative, but on the lower pressure. If I keep the lower pressure, the alveoli will be collapsing at the end of the expirations. Again, during the inspiration, it will open because air is entering into it. During expiration, it will collapse. So this collapsing and opening of alveoli exert shearing forces on the alveolar basement membrane, causing more damage. So this collapsing and opening is harmful. So I want to keep it open during inspiration as well as expiration. During inspiration, it will be anyway open because air is being pushed into the alveoli, right? But expiration, because air escapes, it has a tendency to collapse. So to prevent that from collapsing, we need to maintain slightly positive pressure. And that pressure has to be relatively high to keep it from collapsing. So we follow the high PEEP strategy. Okay. Then the third parameter that you need to remember here is you have to have a target SpO2 and FiO2. Target at SpO2 will be 88 to 94%. You can keep a slightly higher, maybe 90 to 94%, and achieve this with as less oxygen as possible. So give FiO2 less than 60%. That is the target. FiO2 less than 60%, because higher the use of oxygen associated with increased risk of lung fibrosis. Even if patient recovers from ARDS, there is high risk of lung fibrosis. So if you want to avoid that, bring down the FiO2 as quick as possible. That is one target. Now let us go back to the question. Do I need to change the tidal volume here? Absolutely no, right? Do I need to increase the tidal volume? No, right? Do I need to increase the respiratory rate? Generally, we keep the respiratory rates in the range of around 10 to 14 per minute. Okay, we don't need to really give more than that. Here patient is already having a higher frequency. So certainly I don't need to increase the respiratory rate. I have two choices to think of. Reduce FiO2 and increase PEEP. When I look at patient's PaO2 is extremely low, and the PEEP that we are giving is also on the lower side, and FiO2 is high. So I need to certainly lower the FiO2, but how will I be able to lower the FiO2? If I lower the FiO2, already patient is hypoxic, patient saturation will drop further. So it is not going to work. So how will I achieve the lowering of FiO2, I cannot directly jump. The first thing that I will do is, I have still flexibility to increase the PEEP. So I will increase the PEEP and then try to taper the FiO2 and try to maintain an SpO2 of around 90 to 94%. So reduce the FiO2 is a goal for sure, goal of less than 60%, but I cannot do that immediately because patient is already hypoxic. So instead, I will increase the PEEP. That would be my answer over here. I go on increasing the PEEP, and then when flexible, I'll start reducing the FiO2. So answer here should be option D. Option D, we follow high PEEP strategy. Here PEEP had been low, so I'm increasing it. Okay, now let's go to the next question. Here is the question. A young man is brought to the hospital with high-grade fever and altered consciousness. On examination, he had neck rigidity. So we are talking about fever, neck rigidity, and pain when bending the neck. What's your diagnosis? Fever, neck rigidity, right? You're already thinking about meningitis, and you're not wrong. So I'm also thinking about meningitis, and it appears that they have given to us about the CSF finding, and from there we have to decide bacterial hai ya viral hai ya fungal hai, right? They have told that WBC count is slightly elevated, 45 cells per microliter. Measure is neutrophil predominant with an elevated pressure, and a protein normal is 45 milligrams per deciliter. That is also increased. And glucose is 70, not greatly decreased. Okay, so what is your diagnosis here? If given a choice, I would still think that this could be a case of viral meningitis because the cells are not grossly elevated. And always remember, even in viral meningitis, if patient presents early, if you do CSF analysis on day 1, day 2, day 3, you may have elevated neutrophils. Then it becomes lymphocytes. So if I am the treating physician, I'm certainly not going to start antibiotics at this point of time because I may be thinking of this as viral. But anyway, see, one more basic thing is there. Whenever you get a case of meningitis, the recommendation is to start antibiotics. Even if there is delay in getting the CSF done, start empirical antibiotics, because if it is bacterial, the more delay in initiating antibiotics, it is associated with higher mortality. Okay. Now, if I have to make a choice of antibiotics, how I will discuss that. But now, this we are taking it as bacterial meningitis because it is neutrophil predominant. But what goes against bacterial meningitis is generally blood glucose level will be, the CSF glucose level will be very low, and the cell count is expected to be much higher. Anyway, let us take it as bacterial meningitis and answer. Do we use piperacillin tazobactam? No. Do we use amphotericin fusaicin? No. Do we use antitubercular therapy? No. If it is tubercular meningitis, then, right? If it was tubercular meningitis, I would have seen lymphocyte predominant CSF. Glucose will also be low. If it is fungal, it can kind of fit into, but the presentation is quite acute, so unlikely to be. So what am I going with? Again, fungal will have lymphocyte predominant, so it's certainly not lymphocyte predominant. So I'm going to go with option B, vancomycin and ceftriaxone, right? Why this antibiotic is preferred? Because most common cause for meningitis as a whole and bacterial meningitis is pneumococci, right? That is the most common cause, and the second most common cause is meningococci, right? And these together account for more than 2/3 of cases, and this can be collectively well covered with this combination of vancomycin and ceftriaxone, and that's why that's the empirical antibiotics that I'll be going forward here. Okay, now let me go to the next question. Here is the question. Based on the ECG given below, which of the following drugs is not used in the management of the condition? Okay, what is the ECG here? Okay, when I take a quick look, it appears that it is a narrow complex tachycardia, right? Why is it narrow complex tachycardia? The QRS duration is barely 2 small squares, so certainly it's narrow complex. Why tachycardia? When you look at the number of large squares between two R, I know the RR interval is not constant, it is varying. Even when the RR interval is varying, I can quickly gauge that the heart rate will be like, let me say this, when I look at this complex, it is like 3 large squares between the RR, so it is going to be around 100. At points it is less 2, so 150. So heart rate is certainly more than 100, somewhere around 150. If you want more detailed calculation, you can calculate the number of the QRS complexes on the rhythm strip and multiply that by 6. That will give you the precise heart rate. But this is tachycardia, narrow complex tachycardia. Whenever we have narrow complex tachycardia, first thing that we should see is the presence or absence of P waves. When I look at this strip of ECG, I cannot confidently point at any wave and say, okay, I agree that this is P wave. Some P wave like baseline artifacts are there, those are fibrillatory waves, but otherwise I cannot find anything confidently as P wave. So if P waves are not there, then what's your differential diagnosis? You have two differential diagnoses with a narrow complex tachycardia and absent P waves, SVT and atrial fibrillation. Now how to distinguish between SVT and atrial fibrillation? Mainly by looking at the RR interval, right? RR interval, when you look at different wave complexes, you will notice, look at the RR interval here, look at the RR interval here, right? There is varying RR interval. So then what is this? It is atrial fibrillation. What is the preferred drug for atrial fibrillation? As of now, if you have to consider as an antiarrhythmic, amiodarone is considered as a drug of choice for atrial fibrillation. Yes, we can use verapamil, we can use diltiazem too, we can use propranolol too, but have various indications. Here I don't have any information beyond the diagnosis of atrial fibrillation, because if it is atrial fibrillation, I need to know whether it is the atrial fibrillation of duration less than 48 hours or more than 48 hours. If it is less than 48 hours, I'll go for what we call as rhythm correction. I want the rhythm to be converted to sinus. If it is more than 48 hours duration, then probably there will be an underlying clot. There may be an underlying clot in the left atrium, and if I convert the rhythm to sinus, the risk of embolism of the clot is high. So I have to prevent that. How will I get to know whether clot is there or not? I have to go for a transesophageal echocardiography, and if it shows that there is a clot in the left atrium, then I have to go for anticoagulation. What is the duration of anticoagulation? 3 weeks. After 3 weeks of anticoagulation, I can take the patient for rhythm correction. Because all that information is not there here, I am taking it that okay, it is a short duration atrial fibrillation, maybe I can go for rhythm correction, and if I have to go for rhythm correction, the drug of choice will be amiodarone. Verapamil and diltiazem can be considered as second line agents. Okay, let's move to the next question. So here is the next question. What is the question? An elderly female patient with history of severe vomiting was treated aggressively for severe dehydration at an outside hospital. 1 week later, she became mute. She is not talking. She is quadriplegic and she is rigid. So she has developed rigidity, muteness and quadriplegia. So this basically is pointing towards what you call as locked-in syndrome. Locked-in syndrome, which indicates a central pontine lesion, right? It indicates central pontine lesion. And a central pontine lesion can happen because of what you call as osmotic demyelination. It can happen because of osmotic demyelination. What causes osmotic demyelination? The osmotic demyelination can be caused by rapid correction of hyponatremia. So option C would be the answer to go for here. Rapid correction of hyponatremia. The history is also consistent with that. So that will be our diagnosis here. Okay, let's move to the next question now. So here is a question. A patient presents with cough, cold, fever and malaise associated with weight loss and ascites. Radiograph of the chest is given below. So when you look at the chest, I can see opacity in the mid lobe of the lung, right? And then why is it mid lobe? Because you can see the silhouette sign here. The opacity is merging with the cardiac opacity. So it is not the lower lobe. I can see the diaphragm clearly separated from the lung field. But where the cardiac border ends and where the opacity starts is a bit difficult to say. This is a mid lobe opacity. Okay, then patient has, apart from this, right, cough and otherwise he also has ascites. Now ascitic fluid analysis showed elevated adenosine deaminase. Okay, which of the following is the next step in the management? Now elevated EDA, what does that indicate? It indicates tuberculosis. Can this picture be explained with tuberculosis? Yes, tubercular consolidation is known to occur. So we have tubercular consolidation with ascites with elevated ADA. So it is for all probability a case of tuberculosis involving chest as well as abdomen. Okay. Now, in the context of countries like India, if there is tuberculosis, we can start with the anti-tubercular therapy, right? There is no role of conservative management with such tubercular consolidation as well as ascites. Now, biopsy is also not indicated. Then start ATT after laparotomy, stricture removal. No, there is nothing suggestive of stricture from the question. So, what are you going to talk about? Option C would be the straightforward answer of choice. Start anti-tubercular therapy. That's the answer for the question. Okay, now let's move to the next question. Here is the next question. What is the question? A patient was treated for peptic ulcer with H. pylori regimen. Okay, now before I move forward, let me ask you, what is the currently recommended regimen? Currently recommended regimen for H. pylori eradication. Currently recommended regimen. That is going to be quadruple therapy. So in India, no longer we recommend triple therapy. Quadruple therapy, that to OBMT. Omeprazole, bismuth, metronidazole, tetracycline. OBMT is the currently recommended regimen. We need to treat in India with 4 drugs. It's not going to work with 3 drugs anymore. Okay. So he has been treated. Which of the following is used to assess the success of the treatment? So ideally speaking, the investigation of choice for the initial diagnosis can be either urea breath test or more preferably an endoscopic biopsy and then the urease test on the biopsy sample. That's good for initial diagnosis because anyway initially you need to also do endoscopy for visualization of the gastritis and peptic ulcers. But once we have done the diagnosis and started the patient on H. pylori therapy, subjecting them for another endoscopy just to ensure H. pylori eradication is not called for. So non-invasive test will obviously be preferred, and which is more convenient than the urea breath test, right? So urea breath test will be the investigation of choice for confirmation of eradication of H. pylori infection. Okay. Now moving on to the next question. So here is our next question. The given image shows a normal graph on the left and the patient's graph on the right. Which of the following diagnosis can be inferred? Okay. So when you look at this graph, right, this is normal. Look at this and patient's FEV1. Do you agree that patient's FEV1 is decreased? Then when we look at that, patient's FVC is also decreased. FEV1 as well as FVC both are decreased. Now when you look at FEV1 by FVC ratio, because that is the one which helps us to identify an obstructive lung disease. So when you look at FEV1 by FVC ratio, they mentioned it as 50%. 50% over there. Normal, obviously here it is 83%. So what is normal FEV1 by FVC ratio? Normal FEV1 by FVC ratio will be more than 0.7, right? And if it is less than 0.7, it indicates obstructive lung disease, right? Obstructive lung disease. Okay, so now let us come back to it. Once they have mentioned that it is 50%, right? Here it is 50%. So this is clearly a case of obstructive lung disease. And if this is obstructive lung disease, pick up the one, right? Which of the following diagnosis can be inferred from the graph, right? Can it be a chest wall neuromuscular disease? A chest wall neuromuscular disease will lead to restrictive lung disease, not obstructive. It will lead to restrictive. Okay. Sarcoidosis, right? Sarcoidosis also leads to predominantly formation of granulomas. See, remember, sarcoidosis causes both airway disease as well as it causes the lung parenchymal disease. The parenchymal disease will be in the form of formation of granulomas, starting with the hilar lymph nodes, then to the lung parenchyma. Remember that static staging? Yes, it is for sarcoidosis. So because predominantly it is the parenchymal disease, I am going to count it in the restrictive disease. Restrictive disease. Relatively less commonly obstructive disease. Okay. Now idiopathic pulmonary fibrosis or IPF, it's an ILD. So ILD being a restrictive disease. So ILD is also a restrictive disease. bronchiectasis, right? Bronchi. How is the bronchiectasis defined? Defined as irreversible dilatation and destruction of the bronchi. So bronchi are the ones which are irreversibly dilated. Once they are dilated, they are loaded with the mucus and debris and exudates. So they are blocked or obstructed. So it should be an obstructive lung disease. So bronchiectasis is an obstructive lung disease. It's an obstructive lung disease. So for me, the answer of choice here would be option D. That will be the answer. Okay. Now moving on to the next question. Which of the following are signs of heart failure? Okay. So now let us look at the options. Orthopnea, we know it is a sign of heart failure. It can also be seen, apart from heart failure, orthopnea can be seen in patients with diaphragmatic paralysis. It can also be seen in patients with massive ascites because of the push of diaphragm into the thorax, making it difficult for the patient as soon as they lie down. Okay. Now, dyspnea after 2 hours of sleep, it may be a pointer towards PND. So that is, in fact, PND is the most specific sign of left heart failure. Most specific sign of left heart failure. Left heart failure. So it is also finding of heart failure. Okay. Right upper quadrant pain or right hypochondrial pain. Can it be a sign of heart failure? Yes, why not? Because when heart fails, especially right heart fails, there is increased pressure in the inferior vena cava because the blood cannot go into the right atrium from the inferior vena cava. Once the inferior vena caval pressure increases, the drainage of blood from the hepatic veins to inferior vena cava will be affected. The blood will stagnate in liver, and this stagnation leads to what you call as congestive hepatomegaly. This can happen due to congestive hepatomegaly. Congestive hepatomegaly. So this can also be because of the heart failure. But when JVP rises, right, when right side of the heart fails, JVP is expected to rise, but the normal pulsatile nature will be preserved. When you say non-pulsatile raise in JVP, that means JVP is raised and stagnated. It can only happen when there is a superior vena cava obstruction. There is an obstruction, the JVP vein is not able to drain inside, but it will not be pulsatile then. So when you say non-pulsatile JVP, it should point towards superior vena cava obstruction. Superior vena cava obstruction. So answer, which one will be the answer? Option A is not a sign of a heart failure. So then 2, 3 and 4 are seen with heart failure. So I'm going ahead with option C as the answer. So C is going to be our answer, right? Okay. Let's move to the next question. So here is our next question. Resistant hypertension present when patient is on 3 class of antihypertensive drugs, which must include. So basic definition of resistant hypertension is unable to control the blood pressure to target value despite use of 3 or more than 3 antihypertensives, out of which one should be a diuretic, right? So what is current target for blood pressure? Current target BP. Generally speaking, the currently recommended BP is it should be kept less than 130 by 80 millimeters of mercury. So when you are using 3 or more than 3 drugs to achieve BP less than 130/80 and you are not able to achieve, and out of your 3 drugs, one was a diuretic, we call it as resistant hypertension. And they can also ask you another question. If you have a resistant hypertension, right, what is the antihypertensive that you should be adding? The antihypertensive that should be added is drug of choice for resistant hypertension is spironolactone. It doesn't mean that you will treat only with spironolactone. You will continue with what other 3 drugs you are already using. Spironolactone will be considered as add-on. Will add it to the current regimen if you encounter resistant hypertension. The answer here should be diuretics. Okay, now going to the next question. What is the question? What is the management of acute attack of cluster headache? Now, when it comes to the management of acute attack of cluster headache, we have two choices. Acute attack of cluster headache, two choices. One is oxygen and the other one is subcutaneous sumatriptan. Okay. Now, between these two, oxygen is still considered as the drug of choice. It is considered as the drug of choice. On the other hand, sumatriptan is the most effective drug. Most effective is sumatriptan. But drug of choice is oxygen. But how much oxygen? 10 to 12 liters per minute. High flow oxygen. 10 to 12 liters per minute for a period of at least 15 minutes to get the patient experience the relief from the headache. Okay. So choose which suits here now. Oxygen at 6 liters per minute? No, doesn't fit into the picture, right? Again, next option is also oxygen at 6 liters per minute. Many times they will create permutation and combination of this. Like, for example, 2 liters for 15 minutes or 10 liters for 2 minutes, 12 liters for 15 minutes. So choose the one that fits this description that I've given to you. Okay. Since A and B both do not fit into it, obviously that is not going to be my choice. Okay. Sumatriptan oral is not recommended for the cluster headache and probably it is not effective either. But subcutaneous, yes. So option C is also not my choice and I'm going ahead with option D. Sumatriptan subcutaneous is my drug of choice. Okay. Now moving on to the next question. Which wave of JVP corresponds to IVC? What is IVC here? IVC stands for isovolumetric contraction phase of the systole, right? Now JVP, we know A wave is due to atrial contraction, So it's easy to remember A for A. C wave is due to cusp bulge. That means the tricuspid valves cusp bulging into the right atrium, right? And this is the one which is happening. This event is the one which is happening during the isovolumetric contraction phase. This happens in the isovolumetric contraction phase. Okay. V wave is due to venous filling of the atria. Venous filling of the atria. And X wave is due to atrial relaxation. So it is the cusp bulge which is happening in the isovolumetric contraction phase. So option B would be the answer here. C wave is representing isovolumetric contraction. Okay, clear? Now next question. Which of the following drug is the only medication useful in preventing disability progression in a patient with primary progressive multiple sclerosis? Even for now, those who are going to give the next INICET exam, I would consider this as an extremely important question. The question can be rephrased. Rephrased as what? Which of the following is the first drug approved for the management of primary progressive multiple sclerosis? Primary progressive multiple sclerosis. So when it comes to PPMS, we didn't have anything great to offer until recent few years when this drug called as ocrelizumab or ostrelizumab, however you want to pronounce, was approved, right? It is a monoclonal antibody against CD20. Anti-CD20 monoclonal antibody, and this is the first drug approved for preventive treatment of primary progressive multiple sclerosis. Okay, now next question. Here is this. Which of the following is not seen in SIADH, right? SIADH is what? Syndrome of inappropriate antidiuresis. Means basically you have inappropriate release of the ADH. Now when ADH excess happens, what will happen? ADH will go to the kidney and tell it to absorb more free water. So you absorb more free water and cause dilution of the plasma, resulting in hyponatremia, right? Okay. Now let us look at it. Option A, serum sodium is less than 135 milliequivalents per liter. Yes, that is true because there will be hyponatremia, dilution of the plasma. Okay. Urinary sodium will be low. Is it true? I'll come back to this. Euvolemic hyponatremia. See, now what happens in SIADH is there is increase in the water absorption. Okay, but this water absorption will only cause subclinical volume expansion. So peripherally, we don't see patient developing edema or raised JVP and all. So clinically, we will see patient as having euvolemia. So this is also true. Euvolemic hyponatremia is part of the diagnostic criteria for SIADH. Then urine osmolality is increased. If I reabsorb water from the urine and make you lose concentrated urine, what will happen to the urine osmolality? It will be increased. So that is also true. Okay. Now urine sodium is low, right? What happens here? In case of SIADH, you are reabsorbing the water, and because you are reabsorbing the water, you are only reabsorbing the water. You are not reabsorbing the sodium. So you are losing the sodium and you are reabsorbing water, and the sodium that is being lost, right? The urine is getting concentrated. So what will happen to the urine sodium? Urine is concentrated, so urine sodium will be on the high level. So urine sodium is low is false. You are expected to see high urine sodium. So what is the correct answer here? Option B. Option B is the answer to go for. Okay, now coming to the next question. A man presents with the following serum markers profile for hepatitis B. The profile is HBsAg negative. So when you say HBsAg negative, it clearly means that patient is not having any current infection. He is not infected as of now when you say HBsAg is negative, because HBsAg is a marker of current infection. Whether that infection is in an active replicative phase or not, that will be told by HBeAg. So HBsAg is negative and HBeAg is negative. So means that the patient doesn't have current infection. Okay. Now when we look at that, HBV DNA is also negative, so he certainly doesn't have current infection. Then anti-HBC IgM is negative, so it again confirms that he doesn't have an acute infection. Anti-HBC IgG is positive. Only that antibody is positive. So what does it indicate? It simply indicates that patient had an infection in the past. He had an infection in the past, and because of that, he has developed this anti-HBC IgG antibodies. And because he had infection in the past, HBsAg is already turned negative. So what is the answer here? It points towards remote infection. It points towards remote infection. If the patient had chronic hepatitis B, he should be positive for HBsAg. He will be positive for HBsAg. Okay. If it is a pre-core mutant variety, right, then in that case patient might be having HBeAg positivity, then HBV DNA positivity. HBV DNA should be positive. Those are not there. Okay. If it is in the window period, again the DNA may be positive. It is not the case here. So it is clearly a case of remote infection. That would be the answer to go for. Okay. Now moving on. A case of acid-base imbalance can be confirmed by, right? Now what all we need for the diagnosis of an acid-base disorder? I need pH, PCO2 and bicarb levels, right? pH, PCO2 and bicarb levels. Do I need anything more in this for an acid-base disorder? Well, I would require the chloride, sodium, potassium to decide the anion gap if it is a case of metabolic acidosis, right? Okay. pH of the arterial blood, yes, it helps me. pH of the venous blood, yes, why not? Because when it comes to the ABG, we can also do the venous blood gases for diagnosis of acid-base disorder. It doesn't mean that always it has to be an arterial blood gas. If there are contraindications, patient has got severe coagulopathy, you can't puncture the artery, you can do the VBG and make a diagnosis. So VBG, ABG is better, but VBG is also okay. Okay. So option B is also fine. Option D, CO2 of the venous blood, yes, that will also help me. Do I need oxygen for the decision of the acid-base disorder? No, right? I have to decide metabolic or respiratory, acidosis or alkalosis. So all I need is bicarb, carbon dioxide and the pH. I certainly don't require oxygen. So Arterial blood pH can help me. Then venous blood pH can also help me. Venous blood CO2 can also help me. There is no role of the O2. So what should be my answer? A, B, D. A, B, D. Option B would be the answer here. Okay. Now moving on. How do we diagnose diabetes mellitus in a primary care setting? Fasting sugar more than 126 milligrams per deciliter. It should be more than or equal to. RBS more than 200 milligrams per deciliter with classical DM symptoms. What is the classical DM symptoms? Your 3 P's: polyuria, polyphagia, polydipsia, or patient presenting with DKA, or patient presenting with hyperosmolar hyperglycemic state. Only then a random blood sugar level value will be of useful. HbA1c more than 6.5%, yes, that defines diabetes. And 2 hour postprandial capillary blood glucose more than 140, no, it should be more than 200 milligrams per deciliter, more than or equal to 200 milligrams. And then again, postprandial here is after 75 gram oral glucose tolerance test, right? So what fits perfectly in the description is option A and option C, right? Option A and option C. Option B is not perfectly right without these statements. Option D is also not perfectly right. So what is the thing that I'm going ahead where? Option C here. A and C are logically correct options, and that will be my answer of choice. Okay. Now moving to the next question. We have an image here. They're asking an athlete fell while running and died suddenly. The moment question says an athlete fell and died suddenly, first thing that should come to your mind is hypertrophic cardiomyopathy, right? Okay. Now, the cut section of the heart is shown. Which of the following is correct about the condition? So I'm already thinking about hypertrophic cardiomyopathy, most likely obstructive type of hypertrophic cardiomyopathy. Now, what is the most common cause of death in these patients? Mostly because of the VT or VF, right? VT or VF is the cause of death. They are prone for arrhythmia. Okay, now before I answer the option, let us look at the image. When we look at the image, we can clearly see that this is the interventricular septum, this is the left ventricular wall, this is left ventricle, right? This is right ventricle, this is left atrium. So we can clearly see that there is interventricular septal hypertrophy that is asymmetrically literally eating into the left ventricular cavity, making it very narrow, and it almost looks like a banana, right? You can imagine a banana here if you want. This is what we call as banana shaped ventricle. Banana shaped ventricle. So this is classically a case of hypertrophic obstructive cardiomyopathy. It is a inherited condition. It is the most common, I think let me write it down so that you don't forget it. It is the most common inherited cardiac condition. Inherited cardiac condition. Seen in almost 1 in 500 individuals. That common it is. Okay, so it is a heart disease where there is hypertrophy of the ventricle, particularly interventricular septum. Okay, now let us look at the options from bottom up. Is it a valvular heart disease? Technically, we can call it as subvalvular aortic stenosis, but certainly it's not a disease of the valve. So I'm not going to buy option D. Okay. Evaluate for rheumatic etiology? Absolutely not. It is an inherited condition. There's nothing to do with the rheumatic fever or something like that. No. Okay. Screening the close relatives for arrhythmias and structural heart disease and check family members for atherosclerosis. See, atherosclerosis is not responsible for this. This is a clearly inherited myosin protein mutation leading to hypertrophy. So this is also not the answer. So what makes logical sense here is option B. Screening the close relatives for arrhythmias, because it is an inherited condition, so others in the family may have. And see, why are we not screening the patient? Because patient is already dead. Remember that. So that is why the questions options are focusing on the relatives. Now relatives might also be inheriting the same mutation, so they are also prone. And most importantly, the cause of death is arrhythmias, mainly VTVF. So we should screen them for arrhythmias. So I am going ahead with the option B as the answer over here. Okay, so here is one more question. A case of progressive weakness of right and left leg for 1 year and weakness of the upper limb for the last 6 months. So it looks like not an acute condition, right? It's not an acute condition, it's slowly progressing condition. Now on examination, spasticity and brisk reflexes are noted in the left leg. Okay, now this spasticity and brisk reflex indicates what? It indicates upper motor neuron lesion. It indicates upper motor neuron lesion. Okay. Now there is bladder and bowel control maintained, and then they say there is wasting and weakness in the muscles of the upper limb. Wasting indicates what? Wasting or atrophy indicates lower motor neuron lesion. Now the diagnosis has to be very clear, right? So when you say upper motor neuron lesion plus lower motor neuron lesion, there's only one motor neuron disease that could come to your mind, that is amyotrophic lateral sclerosis. In the name, everything is there. The name says amyotrophic, that means atrophy it is talking about. Then lateral sclerosis, so it is talking about lateral corticospinal tract, which is pyramidal tract, which has upper motor neurons. So that name itself tells us that I am having both upper as well as lower motor neuron. So answer is clear, it is option A, amyotrophic lateral sclerosis. Okay. Cervical myelopathy, it is a compression of the spinal cord. Why should cervical myelopathy cause weakness in the lower limb? That is where it goes against the diagnosis, right? It cannot explain lower limb involvement. Then topical spastic paraparesis, right? Not topical, it should have been tropical. Spastic paraparesis. This picture is not a paraparesis, right? Left leg and the upper limb. It is not paraparesis for sure. Okay. Then motor neuropathy with conduction block? No. Right. So this is very clearly a case of amyotrophic lateral sclerosis. So this is the only condition where you have LMN plus UMN involvement. Name itself says amyotrophy, that means LMN, then lateral sclerosis, that means UMN. So that would be the answer for this question. Okay. Now one more question over here. A 25-year-old HIV positive female taking ART complains of pulsatile headache. In an HIV patient, an headache has many differential diagnoses. She is prescribed ergotamine, right? So if she's been prescribed ergotamine, what should I think of as a diagnosis? Obviously, it's most likely migraine. Now she develops tingling and pain in the toe, radiating upwards till mid-thigh. Dorsalis pedis and popliteal artery pulsations are not felt bilaterally. That means patient has developed a most likely occlusion of the dorsalis pedis and also the popliteal artery. What is the etiology, right? What is the etiology? What has she received? Ergotamine is what she has received. Now ergotamine is known to cause the occlusion of the blood vessels, and we call that as ergotism, and that will be the answer. In case of lumbosacral radiculopathy, there will not be absence of the pulsations, right? In disc herniation, there will not be absence of pulsations. Atherosclerosis, yes, that can be, it is a possible option, but I'm going ahead with ergotism because ergot is known to cause, the context fits into it. So we are choosing option D over here. Okay, now moving to the next question. Inhaled nitric oxide is used in the treatment of. Inhaled nitric oxide can be used in treatment of which diseases? Right, mainly for the pulmonary hypertension. Pulmonary hypertension, because we need to cause the pulmonary vasculature dilation, not the systemic dilatation. So that is where inhaled will come into picture. So not for labile hypertension, not for resistant migraine, not for refractory epilepsy. So option A is the answer to go for. Okay, moving forward, here is another question. As you know, COVID-19 can enter the brain leading to meningitis and encephalitis. Well, we all know about it. How does this virus enter the brain? Simple, right? One of the early manifestation of COVID-19 cases was development of anosmia, because virus was using the nasal epithelium as its initial site of entry. From there, through cribriform plate, it can make its way into the brain. So the answer should be obviously option A, cribriform plate would be the answer over here. Okay, so guys, that's it from me here. I hope I've helped you to quickly revise through important PYQs from the INICET. Stay connected on the MEDEC Next channel. We will be solving similar important MCQs in the coming days ahead. And we are running this marathon of the PYQ coverage. So at 7 p.m. or between 7 to 11 p.m. daily, stay tuned to the MEDEC Next channel, where my other colleagues will bring in the PYQs from their respective subjects, and they will try to help you be better prepared for the INICET. Wishing you all the best for the upcoming INICET, and hope this time you will be able to achieve your dream. Thank you.